All right, let's get started. So let's talk about cesarean deliveries. There are times when we have to emergently do a cesarean section. If the fetus is having a lot of decelerations for whatever reason, and we need to deliver the baby. So let's talk about planned or elective C-sections. So sometimes if the mother has a heart condition, cardiac disease, coronary artery disease, aortic stenosis, Marfan syndrome, which is a heart, mostly heart. There's other things about Marfan, but so, and these clients, a placenta previa also, or just a malpresentation, breech position, transverse position, we need to do C-sections on these clients. So they're elective and planned ahead of time. So the care plan as nurses, what we need to understand and know is that we need an informed written consent for the actual procedure, cesarean surgery, and for anesthesia. Make sure you double check the orders. They'll probably want to type and screen or type and cross for blood to have it available, and other labs. Ultrasound, last minute ultrasound to verify fetal position. We also need to put some sequential compression devices on our clients' legs. And that, do anybody know what those are?
Yeah, they're like a little electronic boot like wraps that you put around the legs, and they just squeeze back and forth to move the blood better and make sure that you don't get DVTs.
Good, perfect, yes. So anybody who's having major surgery need those, or anybody who's non-ambulatory needs to have their calves massaged to keep that blood flowing. And then a Foley catheter. Why do we need a Foley catheter for a C-section? It doesn't take very long to do a Foley catheter. I mean, does it take very long to do a C-section? Why do we need a catheter?
Because of the epidural or spinal tap. Right?
She won't be able
Can
to
you-
feel from the breast down, so you need to put a Foley in.
So that we can keep the bladder empty. Yeah, okay. What else? Why else?
She's gonna lose the ability to actually urinate. She won't be able to control those muscles. And
Okay.
so until she can get that function back after, you need to be
Okay.
able to prevent retention.
Okay, good. Okay. What else? What other reasons do we want it in there? Can you think of any other why you would want it in there for any other reasons?
Probably
When
to
a cat-
keep the bladder empty the whole time. That way it's not in the way.
Yeah, so it's not in the way of the surgery, because remember the bladder lies above, on top of the uterus. Even though the uterus is large this way, the bladder is in front. And if we're doing a low incision, we got to keep that bladder empty. And if we put a Foley in there, it's going to stay empty and prevent accidentally nicking the bladder, causing it to leak, damaging. Okay, so we need to keep it depressed for that reason. And there's one more reason we need a Foley in.
I'm thinking about like after the C-section, because we need to massage that fundus and help contract it since it was a C-section and not a vaginal.
Okay, good point. And we also need to have strict INOs with major surgery. We want to know what her urine output was, how much blood did she lose, and and so anesthesia is keeping track of how much IV fluids he or she has given, so we have an accurate INO. Okay, all right, good. So if it's an emergency section, if you are you're caring for a client that had a placental abruption, and everybody's rushing around trying to get her to the OR to do a C-section. What kind of anesthesia would we be providing this client if she did not have a spinal or an epidural? What kind of anesthesia could we provide?
Pudendal.
Would it be a general if it's emergency?
Yes, general anesthesia. So where we apply a mask, give her some gas, and begin to anesthetize her and intubate her, okay, and then continuous infusion or respirations. We have to breathe for her. So general anesthesia, okay, if it's an emergency. If it's not, if it's elective, we can do spinal or we can do a continuous epidural.
So
Okay.
with giving general, once they have the baby out, are they going to have to take them to the NICU just because you are giving them like CNS depressants?
No, no, no. We actually do have to recover mother though. Okay, mother has to go to the recovery room for at least an hour, so she doesn't have that bonding skin to skin time while she's recovering. We begin that when she's recovered. Okay, so the nursery nurses have to take care of the baby. Okay. Okay. And yes, there'll probably be a little sedation with the fetus. Usually they do have a little bit of transient tachypnea because they don't have the advantage of passing through the birth canal and having their chest squeezed to get rid of even more amniotic fluid. So when we deliver them from the uterus via C-section through the abdomen, they don't have that advantage. And so a lot of times they have a little bit more difficulty with tachypnea or breathing quickly, trying to get rid of the extra fluid. Okay. So blood clots, we've talked about sequential compression devices. We've talked about infections. There's always infections associated with surgery. So we prophylactically treat all surgery with an antibiotic prior to incision. Okay. Fetal asphyxia, not uncommon because of the extra fluid that's in those lungs, respiratory distress, and then of course mother's blood loss. How much blood loss estimated is lost during a C-section? Anybody remember?
800 to 1,000?
It's 1,000.
Up to 1,000, yeah, even up to 1,000, a whole liter. Okay, here's your picture of your C-section.
We can't see it.
You mean you haven't been able to see my picture?
No, ma'am.
Y'all should have said something. It's the wrong. Let's see, where is it? What do you
I
see
thought we
now?
were just talking about it, the baby.
Oh, you do see the baby now? Okay,
Yeah.
good. Oh, good. Okay. So let me go back to this slide. So this is what we were talking about. Okay. Now, Nathaniel, you're off screen again. Where's your camera? Nathaniel, can you hear us?
My camera isn't working. I don't know what's going on. It's just like black. My camera's on. It's just not working.
Oh dear. Okay, I'll see what you can do next time to fix it, okay? All right. Okay, let's talk about some emergencies. What's this a picture of? Now that you can see. If you have a client in labor and you notice that the amniotic fluid is discolored, it has a green tint to it, then you know that your fetus has passed meconium before delivery. And this picture that I have here, this looks like a post-term baby. And not uncommon with a post-term baby to have a lot of amniotic or to release stool. So it's called meconium stained amniotic fluid. The very first stool that a newborn passes is also called meconium. Okay. So during labor, if your fetus has experienced a lot of hypoxemia, and then hypoxia, that stimulates that vagus nerve, which relaxes the rectal sphincter, and that's why they pass that stool. So if you have during labor a lot of decelerations, cord prolapse, you might notice that when we do a C-section that there's meconium there. And so the problem is not while the baby's in the uterus, it's afterwards when you deliver that baby and there's meconium on them. They will aspirate it. Okay. So then they get very sick and develop like a pneumonitis. So we don't want to do deep suctioning of these babies. We do oral suctioning. Nose then or mouth then nose. We suction the mouth first, always, and then we suction the nose. So when you suction the mouth, just suction the sides. You don't want to gag your newborn. That would be terrible. You just want to do the sides, not on top of the tongue and in the back. Meconium aspiration syndrome. Another emergency is shoulder dystocia, the turtle sign. So the turtle sign, think diabetic, okay? Large baby, right? Broad chest, broad shoulders. Those shoulders get in the way. You can see in this picture, they're actually doing the McRoberts maneuver and suprapubic pressure. Okay, so just above the pubic bone, pressing in, that will push that shoulder down, and then the shoulder can be released out from underneath the bone. So the head is born, but the shoulder can't pass. So that what you'll see is the head push forward and then pull back. Once again, this can cause problems with fetal asphyxia. And because you're pushing down on the shoulder, you might break the clavicle or the humerus bone. And the brachial plexus injury on the opposite side, which we talk about more with high-risk newborns. And then damage to the pelvic floor, hemorrhage, some things we think of with shoulder dystocia. Here's another picture. One person supports the fetus head and the other one applies pressure. It usually takes like 3 or 4 people because one person on one side will support the leg and the hip in that position. And one person then can support the fetal head. And you notice how they're pushing down above that bone, right above that bone, and how that shoulder is going inward. And that allows the baby to pass. Umbilical cord prolapse. Why is this a problem? Why is this considered an emergency?
Doesn't it cut off the baby's airflow? It's outside of the body, right?
Airflow. Is it airflow it's cutting off?
Perfusion.
Perfusion, yeah, it's cutting off the blood flow, okay, where the oxygen is, okay? Yes, it cuts off so baby doesn't get any oxygen, okay? So that's a problem. What do you think the answer to this is? What would you see on the fetal monitor that you would suspect that this is going on?
Variable D cells.
Okay, the variable D cells, very sharp drop. You cut that cord or you press that cord and it drops just like that. Okay, so it's a V shaped. So variable deceleration. So what do you think the resolve to this is? What would you do?
Move
Hey.
the mom.
Don't you put mom on her all fours? Change the
Positioning,
position.
repositioning.
Repositioning, good answers. So, if the cord lies before or below the presenting part, sometimes after the rupture of the membranes, if we artificially rupture the membranes and the fetus is not engaged, sometimes that cord will fall down. If the cord is just very long, okay, baby's in a breech position or transverse position, and that cord can slip down, okay? So variable decelerations and then prolonged decelerations during contractions. You might also be able to palpate that cord in the vagina, or you might actually visualize it, okay? Stay with your patient, reposition her to the knee chest or all fours, or Trendelenburg, anything that would help, gravity would help pull the baby back down into the uterus away from that cervix, okay? Put on sterile glove. You've got your whole team in there to help you. And you're going to push on the head or whatever part is presenting. You're not going to push on the cord. How many of you, don't tell me, but how many of you answered to push on the cord in the quiz? Anybody? You're not doing any good if you push on the cord, right? Because you're just pinching it. Okay. If you just push on the presenting part, that will help. And then we can get her some oxygen, get her fluid. We're calling the provider, calling the OR, calling anesthesia. And then somebody's going to give you, as you're pushing on that head, give you a sterile towel that's moistened with some saline, sterile saline, and you can wrap it around the cord. You want to keep the cord moist so it doesn't lose fluid. Okay. It's an emergency. We're headed to the OR. And here's just some more pictures that help you understand how important that the position change might be the answer, you know. It might allow that cord to perfuse to blood flow to the fetus. Okay. Trendelenburg, if you can't do knee chest, if she has a spinal or epidural, then we can do Trendelenburg. Modified Sims would be up on her side, but elevate those hips a little bit with pillows. Uterine rupture. So uterine ruptures are associated with scars on the uterus already, or maybe trauma. Okay, it's very rare. You can see the rupture pictures I have here, how massive. You know, we've got so much blood in the uterus during late pregnancy like this. And then if you're having contractions, if it's during labor, then that makes it worse. So monitor for making sure she doesn't have too many contractions, too strong. Be careful with the oxytocin. Okay. So what you would see is, you know, abrupt change in the fetal heart rate pattern, maternal pain. Okay. Maternal pain, massive bleeding, life-threatening. And you can see on the monitor what happens. The baby heartbeat drops off. Mom's losing an awful lot of blood. It's extremely rare, but uterine rupture, I didn't even have it on here. Okay. And then the last emergency is amniotic fluid embolism. What do we mean by embolism? Just the term embolism.
A clot that travels.
Something traveling in the blood, right? It can be amniotic fluid. It can be blood clot. So where does it go when that blood circulates? Where does it end up? At the end of the cycle, going back to the heart, right? inferior and superior vena cava into the right atrium, into the right ventricle, pulmonary artery to the lungs, right? So when it gets to that pulmonary artery, that's what happens. There is an embolus of blood or an embolus of amniotic fluid. It blocks that pulmonary artery and your client can't breathe. So what you see is sudden respiratory distress. So it's also called anaphylactoid syndrome of pregnancy if it's amniotic fluid. Okay. It can occur during labor, during the birth process, after delivery. Sudden respiratory distress, cardiovascular collapse. Okay, heart stops. Coagulopathy, which is your DIC, blood clots everywhere. Acute hypotension. And then, of course, maternal hypoxia, the DIC is worse. Bleeding. Okay. What are some signs of cardiovascular collapse? If the cardiovascular system is collapsing, what's going on?
The vital signs?
Okay, losing vital signs. Physiologically, what's happening?
Are you talking about like the crackles in the lungs and
Well, there's you won't be able to hear them because the air's not passing. So the heart, the blood flow stops. Okay. If the pulmonary artery is blocked, the blood flow into the heart is stopping. Okay. It doesn't get to the lungs. It can't get to the right atrium because it's blocked. Can't get to the right ventricle, can't be moved out. So the coronary arteries are not filling back up. So there's no activity. It's collapsing. Okay. Some other causes for amniotic fluid embolus is meconium stained amniotic fluid, precipitous labor, uterine tears, cesarean sections, placental abruption, placenta previa, severe, if she goes into labor. If this occurs, I've never seen an AFE. I've never seen it. We do CPR for 4 minutes. If we are unsuccessful, then we have to do a C-section to save the baby. Okay, if we can't save the mother, we have to save the baby. Of course, 4 minutes of CPR is what the textbook says. You need to know what your protocol for your facility is. Okay, so, you know, if you have a client that has these symptoms and signs, you really don't know if it's amniotic or a blood clot, but you treat them the same. Okay. The outcome is never very good with either one. I think that's the end of our slides. So that is not as much, we didn't have to go through as much information this week as we did last week. Do you have any questions about content from last week? You don't remember what it is, maybe. You feel too, you don't know where to begin to ask questions? That's okay. What are some of the things, those of you who have attended study sessions, what are some things that you have learned that you didn't know prior to the study session? I mean, has it helped you with anything? Okay, that's all right. So let's look at your announcements. Yeah. So this is the last announcement you see are about homework grades. And then I've been putting the the sessions, all the sessions in here, the recordings. So far, everybody except mine, which will be added here tomorrow. Okay. So you can click onto those and watch those for your exam. And then the clinical pathway, I have a chart in here about diabetes that might help you out. And then I want to show you, there's Kahoot game recordings I'll put in here. And then right below it says week 4 concept map templates. Okay. I put in a PowerPoint and then a list of concepts. Concept may, and then the template itself. So you can take, for your exam too, you can take these concepts and you can fill out a concept map for each of them. Okay. And that will help you on your exam. So in the list, you can see labor complications. We just went over that. So pick out a couple complications. You can choose. I have preterm labor already listed here. You can do anything like post-term pregnancy and work through the concept map. I have postpartum assessment and complications. So postpartum hemorrhage. What would you see? What would you do? Preeclampsia and help. Bleeding in pregnancy. And I just added a short video about bleeding in pregnancy in with the other short videos. Fetal surveillance. So that's going to be kit counts, fetal kit counts, BPP. So what I want to show you is this. Here's the concept map. Now, some concept maps aren't this complicated. Okay. So in this concept map, I have the concept in the middle, postpartum hemorrhage. There are several questions on the exam about postpartum hemorrhage. Okay, so you need to understand the postpartum period. Who's at risk for a postpartum hemorrhage? The risk factors. Okay, what are some signs and symptoms that your client is hemorrhaging? What would you see? Etiology, pathophys, in other words, what's causing the hemorrhage? What could be a potential cause? Okay, labs and diagnostics. What might you see in lab work if she's hemorrhaging? And then, of course, medications and treatments, potential complications, education. How do you know your interventions worked? In other words, how do you know what you did for your client to get her through that bleeding period? What did you do? How do you know it worked? Is she stopped bleeding? How do you know? Okay. So what I'm doing, we only have a few more minutes left. Sam, I lost you. Where are you? Mabel must have stepped out. You guys, there she is.
I'm here. I'm just trying to get a book from my car.
Okay.
It's still
All right. So what I'm going to do, let's see, there are 19 of us at 5. I'm going to send you all to breakout rooms. And I want you to do a concept map on postpartum hemorrhage. Work as a team so you can divide and conquer. Some of you work on risk factors. Some of you work on the signs and symptoms. Don't have to get it all finished. I'll give you 15 minutes to work on it, and then we're going to go through it together. so that you know how to make a concept map for the rest of those concepts, okay? So if you want to take a screenshot, or if you want to take a picture with your phone so you know how to do your map, see. All right, I'm going to open the rooms up and you should be receiving an invitation. Courtney, Courtney. 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 I sent you an invitation, Mabel. You're supposed to join your room. I think I put you in room 3, Mabel. You see the room invite? Go to the breakout rooms and go to room 3. Okay. Okay. So postpartum hemorrhage, what did you come up with? Let's start with group. Let's see, stop sharing that, start sharing. There we go. Group 3, what did you come up with? Etiology, pathophysiology, or what did you come up with?
So the definition of the postpartum hemorrhage is that you've lost more than 1,000 milliliters in the first 24 hours for any birth process. So that's what I was finding as far as like the most current definition. And there's two.
Where did you find that definition, Rebecca?
It is with the National Center of Biotechnology Information. It's the NBIC. I usually try and check there.
Okay.
Yeah.
Okay. For testing purposes, then it would be 500, more than 500 for
Okay.
vaginal, more than 1,000 for C-section. So, okay, good,
Okay.
good. I love it. See what Rebecca does. She's looking at evidence. Okay. We make clinical decisions based on evidence. As long as the source you're using is a professional choice. Okay, a professional resource. You know, avoid Google, avoid all those other things, but a professional research journal, preferably. Okay, and then the National Institutes of Health, the government websites also will have good information. Great, thank you, Rebecca. What else in that? Who else was in that group?
Me.
Fritz? Fritz, you were in that group, weren't you, or not?
Yes, I was. Yes, I was about the risk factors. We have the placenta abruption. The placenta abruption is when the placenta disconnect from the uterus. This is a very
Okay.
serious condition.
Okay, okay. Well, see, remember, postpartum, this is a postpartum hemorrhage, so the placenta's already gone, but it's a hemorrhage, right? A placental abruption is a hemorrhage, and so we treat it a little bit differently, but we're gonna take care of it nearly the same way. Okay, so what else?
Placenta previa, the placenta previa is when the placenta go and obstruct the uterus, something like that. The blockage, the neck of the
Okay,
uterus.
okay, all right, yeah. So sometimes that can cause a hemorrhage too, okay? All right, so what other risk factors are there for a postpartum hemorrhage?
Infection. Infection can cause that.
Okay, good. Okay, good. Infection inside the uterus. Okay, what else?
Lacerations or hematomas.
Oh, good, good. Okay. If mother
Hypo-
had, go ahead.
The mother is risk to get hypovolemic shock. We are trying to prevent that because with the 20% of blood lost, she can be in hypovolemic shock.
Okay, okay. So, Mabel, your camera's not. Nathaniel, I see your camera's working, but I don't see your face. You need to stay in front of your computer. Okay. All right. And Mabel, your camera's not on. Boy, it's not been a good camera day for us. Okay, so yes, so just a little bit of trivia. If a client has lost 25% of total blood volume or greater, we need to replace it with whole blood and not just fluids. Okay. Okay. Any other risk factors you can think of, what you would be really in tune with, and you're concerned about hemorrhage?
If there's a
Possible
tear somewhere,
Okay, yeah, cervical tear. Okay, good.
Prolonged
Multiple-
third stage
Multiple
of labor.
pregnancies.
Yes.
Multiple pregnancies, prolonged labor. Good.
Polyhydramnios.
Polyhydramnios. Yeah,
Yes.
so if there's a big baby and the uterus is really stretched and a lot of fluid, it's going to be hard for that uterus to contract after delivery. So yeah, she's at risk. So
History of postpartum hemorrhage too.
okay, great, great. I love it. You're covering all the bases. That's great. Good job. So what are some signs and symptoms then?
We had a question about that. Our group had a question about that.
Yes. Go ahead, Thomas.
So we were thinking if a patient have a bulgy uterus in its autonomy and the number one cause is a full bladder, can we straight cath them to get the urine out of them? Okay.
Oh yeah, yeah, yeah. If they can't void, yeah, you'd have to catheterize them. Yeah, yeah. Of course, you always want to try to have them void, you know,
Right.
because when you do a straight catheter, it's invasive, right?
Right.
And it might cause an infection. So okay, good. Yeah. Anything to get that bladder emptied. Okay, good. So signs and symptoms. What are some early signs of postpartum hemorrhage? You said a boggy
clammy
uterus.
and pale skin,
Okay, that's getting later. So hemorrhagic
Uncontrol-
shock,
Uncontrolled
we're gonna
bleeding.
see.
bleeding,
decreased blood
Soak
pressure,
pads.
tachycardia,
bleeding.
So we're going, okay, so we're going into shock. We're going, your client's going into shock because you weren't prepared, okay? So tachycardia,
clammy
pallor,
skin.
somebody said pale, clammy skin,
Clammy skin.
hypotension,
hypotension. Those are all late signs. You know, you don't ever want to get to that point, okay?
What about the
Good.
vital sign? The vital signs like oxygen. We see the mom oxygen get low.
Okay,
Respiration could
What'd you
be
say?
okay,
faster.
okay.
If
So
you wanna
those are late signs, okay?
Late,
Heavy bleeding, like
Eh,
your soak pads, if there's more than 4 in like, what, is it 15 minutes?
Yeah, yeah, it's like filling a pad within 20 minutes or 30 minutes.
Yeah.
That should be a red flag, okay?
Bleeding.
okay.
Bleeding, yeah,
Oh,
yeah. Filling
in
those
the
carry pads up, yeah.
Boji
Good.
utero.
Would hypotonia be
when-
like an early sign or a late sign?
So a hypotonia means that the uterus might be contracting a little bit, but not enough. She's still bleeding a lot. Yeah.
Let's just say-
Atonia or atony means it's not contracting at all. So atony. And the first thing, and I love it, you mentioned was the bladder's full. Okay. So that is number one. You know, it's that bladder is full. Okay. Especially if she had an epidural. She doesn't realize her bladder is full. Okay. So what are complications? Well, death, right? Yeah. What would your interventions be and medication treatment?
Oxytocin.
Other than emptying the bladder, what else do you want to be doing for your client?
Massage the
massaging
uterus.
the front. Massaging, making
Good,
sure it's firm.
massaging the uterus, yes.
Making sure it's firm.
Oxytocin.
Oxytocin, we can give some drugs,
IV
oxytocin,
fluids.
IV
Yes.
fluids.
Hemobate.
Hemobate is a choice. Unless she has what?
asthma.
Asthma.
Isn't
And
there like,
methogen unless she's hypertension.
Okay, good.
isn't there like that little device that you can put just inside the uterus to try and close that off?
Tamponade, you talking about a tamponade?
Maybe.
Hello?
I saw it when I was at clinical. I don't
Okay.
remember what it's called.
What did they do?
It was
So
just,
you-
it almost looked like an IUD, but it went like by the cervix.
Okay, okay. So
Um,
they're,
I'm
go
sorry.
ahead.
Is there some tablets that you can also use anally?
Uh-huh. You
Okay.
remember what those are?
I don't know. I seen it in clinical and everything happened so fast. I'm not sure what they use, but I know the doctor, she like put several tablets in there.
Okay. And does anybody know what the medication that is? It's the same medication we
We
use
just
to
talked
ripen the
about it.
cervix.
Didn't we just talk about that?
Okay. Okay.
It's the same medication, but for postpartum hemorrhage, it's a much higher dose. So what is it? Does anybody remember what it is? What class of drug it is?
Oxytocin.
No, not tablets into the rectum.
Oh, into the rectum.
As long as she didn't have any lacerations.
It's some kind of progesterone.
Not progesterone,
No.
Prostaglandin.
prostaglandins. Yeah,
Oh.
prostaglandins. Yeah,
So wouldn't that be
it'll
more?
make that, it'll make the cervix soft, but it also can cause contractions. So we give a high dose, it's gonna cause contractions.
Hmm.
Okay, so we give like 1,000 milligrams.
Okay.
Okay, very good. And so how do you know it worked?
Her blood
Assess.
cell count is back up. She's not bleeding as much anymore.
Okay, that's kind of a simple answer, but it's true. It's true with any drug or any intervention you do as a nurse. You go back to your client and you reevaluate to see has the client's condition improved? Has what you did worked? Okay, so you're reassessing as you're evaluating as you're reassessing. You're evaluating your interventions. Good, 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 good. So this is how you need to think, okay, as a nurse. Take the concept, put it in the middle, and think about, okay, now, where would I see this? What are the potential risks associated with it? What kind of clients and what would I see? Okay. All right, so it's after 5:30. Thank you for staying, and hope it was helpful today. And please try to come Saturday night. Look at all of your resources. I'll be glad to meet with any of you this week if you want to meet again, tutoring, whatever you need before your exam. You have time to let me know and reach out, okay?
Thank you.
You are welcome.
Thank you.
Thank you.
If you've never met with me, I recommend that you say, yeah, I want to meet with you, and we'll come up with a time and day.
Dr. Zeller, I have a
Yes, Maria.
question about the NCLEX homework.
Okay,
So on our weekly modules, it says to do newborn and postpartum, but then when I hopped on class and in the announcements that I saw, it says to do the intra, and post.
yeah.
So I already did the newborn and postpartum. Should I just try for
Did
the?
did you check the health problem instead of content area category?
I did content area and then I went to maternity, but I was going off of the modules because I did the
I
NCLEX
know,
like a
yeah,
couple
and I
days
tried to get
ago.
that changed. That's why in the announcements, I tried to explain to you, so you don't have to, if you've already submitted, that's fine, but for your own benefit, you
Right.
might want to go back in and do some of those NCLEX questions and choose the health problem category and then maternity. And you don't
Okay.
want, you try to avoid newborn.
Okay, so I mean, I didn't submit it. I got an 84 on it. I was just gonna see if I could submit that or if you'd want me to just do.
And that is entirely up to you. You can go ahead and submit it. It doesn't matter.
I just don't want to get dinged, so that's my only.
Oh, you're
concern.
not going to get dinged. I'm not going to ding you for that. No.
Okay.
no.
Okay.
No.
I'm gonna go ahead and try to do the other ones and see if I get a good grade.
Yeah, well, you can, or you could do small groups of 10 just as in preparation for taking your exam.
Okay. Okay.
Okay.
Thank you. I
You're
appreciate it.
welcome. Oh, yeah. Yeah.
Have a
Good
good
question.
one.
You too.
Bye.
Bye-bye.